Vision, seeing with our eyes the people and the things around us, our reality. In a mirror, seeing ourselves and where we have come from, our past. Through the Hubble telescope, seeing 12 billion light years away, unimaginable. For the vision impaired, seeing through our other senses. Vision, an ability or imagination to think about or plan the future for the way things might be. Before we discuss Vision 2020 with our lineup of respected and highly motivated guest pharmacists, let's take a moment to explain FIP and the community pharmacy section. FIP, through associations and individual pharmacists and pharmaceutical scientists, and representing 3 million practitioners, brings together people committed to improving global health. One of the several interest groups and sections of FIP is the Community Pharmacy Section, CPS. The section seeks to be another touch point for community pharmacists to help them in the delivery of medicines, health products, and services that will improve medicine use and advance patient care. One recent project developed by the section has been Vision 2020, led by Emma Polino of Portugal, a look into the near future of and to highlight the key components in community pharmacy practice. In this video, 10 internationally recognized pharmacists will speak to each of these key components. At the end of the video, we will post a web link to the references and resources associated with each topic as provided by our guests. The Community Pharmacy section sincerely thanks our guests for sharing their time, knowledge, and opinions on the CPS Vision 2020. My name is Warren Meek, President of C7 Consulting, and I am pleased to be the narrator for this video. Our next guest is Dr. Lisa Guirguis from Canada, speaking on communications, relationships, and collaborations. Lisa, it seems that patients are still not aware of the real value of a pharmacist. Can you comment?
When we do research, or I've done a scan of the research literature recently for another project, we definitely see that patients, the majority of them see pharmacists as someone who dispenses their medication. That being said, it varies. If someone is ill or has a need and has a pharmacist who's met that need, they understand the role of a pharmacist immediately. I still think the bulk of the population doesn't understand what we do, and that's our fault. I'm not sure that media campaigns are going to change that. I think that almost has to be changed when the service in the pharmacy changes. When you experience care, people get it. Anyone who's had good care from a pharmacist gets it, right? So, while I value the media campaigns and I realize they're a good thing, I don't think it's going to work unless people are receiving that care at the pharmacy. And a lot of patients are. We have to, like you said, leave the door open so next time they know to come to us, because they're not coming to us. They're going to Dr. Google, they're going to their friends, and these are great resources, just they need someone to synthesize that for them, and that's us.
Lisa, what are your thoughts on the current relationships between community pharmacists and other healthcare providers?
To be quite honest, I don't know if we have relationships always with other providers. We're in a network, I think. Community pharmacists, we're like a hub and we spoke out to people. But we might have a relationship with one or two really close providers, but generally we don't have relationships. We're more of a network service. And I'm not sure if that's the best way to do it, but I think it's a more accurate description. The fellows in Iowa have done some great research where they actually talked about how to build a relationship with a physician mainly, but you could do that with a nurse practitioner, a physiotherapist, or anybody. And generally it talks about how you should get to know the person, find their needs, and then help them with a patient to build trust. And then that relationship works up. And I think that's what happens. When pharmacists have a quick win or they really help somebody with a patient, then they develop a relationship with that care provider. This is almost the same as what I was saying about patients. When they need us and we meet their needs, we build a relationship around that.
Lisa, what advice do you have for pharmacists who want to provide better care for their patients?
A couple things. I start every talk I do with pharmacists by saying community pharmacists save lives every day. And I want us to realize we're doing a very important role. And if our community pharmacists were to disappear off the face of the earth, there would be an enormous health crisis in every country. right? I firmly believe that. And once pharmacists, I think they need to believe that they're doing a good job. And I think that's where they need to start. And I mean this from the bottom of my heart. This is why I went into research, was to help prove what they're doing. I think pharmacists who want to provide better care, I think they need to reframe their role. I believe, not all, but a large proportion of pharmacists believe their role is to give patients information about drugs. I think pharmacists' role is to monitor drug therapy. And when they find a problem, then provide tailored information. So you've really got to believe new fills are boring. Refills are where the action is. Because refills are when we can say, how is your beta blocker working?
Yes.
Right? Especially first new fills, or if you haven't talked to them in a while. I get you might not want to talk to someone every month about their oral contraceptive, but maybe you need to leave the door open every month and say, how's it going this month? You know, and maybe at a certain time, like every 6 months to a year, you do a little bit of screening questions. Are you smoking? And a few things you might be concerned about. I think we've got to change our role. Our role is to monitor therapy. No one's doing this in the healthcare system.
Thanks, Lisa. Do you see us getting to a technologically advanced system that can algorithmically identify those patients that we really need to focus on? Or is it really a matter of chart review?
Do you know what? We need to talk to people. Because most of the problems, that we can get the algorithm stuff pretty quickly right now, and we're not doing enough of that. But at the end of the day, if someone's experiencing an adverse event, we can't get that out of an algorithm right now. And a lot of patients, they don't know what's wrong. Can I give it lots of examples? Patients will deal with almost unbearable side effects, but they don't know that they're a side effect. Or they don't know, they're afraid. There's evidence from clinical trials that patients won't admit the side effects because they're so afraid they're going to take the drug away. So if you had depression and this was the first drug that worked, but yet you were having a terrible side effect, you would not admit it because the fear of depression is greater. So I'm more worried about those problems. And because other people can look at the databases, we're the only ones with the patients in front of us. I think that's where the screening is going to occur that is unique to our profession.
Thanks, Lisa. What tips would you suggest for pharmacists, pharmacies, pharmacy organizations to achieve better patient health outcomes?
The phrase I've been using is you need to recognize or engage the person behind the prescription. Because there's a person there. And if you talk to a pharmacist about their day, and I do this in my research, I say, can you think about the last patient that pharmacists have a hard time. If I say to them, can you think about the last time you dispensed metformin? It's much faster for them. So we all have these ways of conceptualizing patients as their medical problems. And you know what? It's efficient and it helps us get through our day. And I'm not saying it's all wrong, but when we're in front of the patient, we need to pause for a moment and remember that there's a real person there. We really need to say who we are, what our name is, and to use someone's name. If at all possible, people love the sound of their name. It does provide instant connection. Okay? And I'm not saying use it in a false way or use it if you really can't pronounce it. But if you can and you're familiar, use it. The next thing I think we need to do is ask the patients what they want today. And it's called agenda setting. You know, I'm here to talk to you about your medication. What else could I let you know about today? And do that big invitation, because you've all done that consult where we talked about the med and then we went to ring it in and they found out how much it was and they wouldn't pick it up. And I know it's a very pharmacist-centric problem, but the idea is if we get the problems up front, we can address them. Probably the next thing I would really suggest is to listen for cues. A lot of the time, and I have tons of audio recordings of this, of patients and pharmacists, and it's really easy to pick up when you're listening to the audio. I realize it's harder to do when you're the pharmacist. But patients will say things like, well, you take that 3 times a day, and the patient goes, oh, if I can remember that, and then the pharmacist keeps on going. And they don't hear that the patient just hinted to you that they can't remember, right? Or sometimes the patients will bring up a patient, I have an example of a pharmacist is talking about how to take this antibiotic, keeps going, but I eat spicy food. And the pharmacist just ignores this spicy food thing, and we never find out what the patient's concern is, right? But he has a concern about spicy foods. And because it doesn't make sense to the pharmacist, they don't deal with it. When patients bring up odd things or even little things that seem insignificant, it's usually a pause because patients don't bring up random things usually. They only bring them up if they think they are connected. But they're not going to tell you, they're only going to hint. Some patients, not all. So we have to listen and deal with the hints. So I think that's really important in the engaging the person.
Lisa, those are great examples. Certainly doable from your perspective?
You know what? When we time pharmacists in community pharmacies when they're talking with patients, we find on average they spend 2 minutes to 3 minutes with the patient and only about 30% of that talking about the medication, 70% of it ringing it in or dead silence. Right? I'm not suggesting we do more time. I'm suggesting we use the time we have. Right? Now, if you're not talking to the patient at all, that's a different workflow issue. But in the people who are already talking to patients, they have 2 to 3 minutes, and they need to refocus that time to use it for medication safety and for connecting with the patient to find out what's going on. It doesn't take long. And remember, most places now, we have a medication review. Book them in for later. If a problem comes up that you can't solve, this is an opportunity to offer a cognitive or a patient-centered service. You know what, I can't talk to you about that right now, but I can sit down with you later in the week and we can work this out. So I think it's an opportunity to identify problems. It doesn't mean we have to solve them right away. And it's not, a lot of pharmacists dislike talking about med reviews, right? Because they feel like they're selling them, right? And we're not. We're offering a service that's needed. We just have to figure out who needs it. When screening patients, I believe in the 3 prime questions model. In Alberta, we call it chat, check, and chart, and it's the chatting part. And it's also in connecting care and what we call vital behaviors as well. And there's 3 questions if you could ask every patient. The questions are something about purpose. What are you taking this medication for? A lot of pharmacists are hesitant to ask, but how can we check if the dose is safe if we don't even know what it's for? Because dose depends on that. And how can we check if it's indicated if we don't know what it's for? The second question is, how are you taking it? Right? A lot of patients have some difficulty with their med. How are you taking it? If it's a new prescription, I would ask, how are you told to take this? Or, how are you going to take this when you get home? How are you going to take it tomorrow? You want to know what the patient knows, and then you want to give them tailored information to fill in the gaps. So that's the 2 questions. The third one is about monitoring. And it's really, if it's a new prescription, what were you told to expect? Or what do you expect with this medication? And that's both benefits and negatives. If it's a refill, then I call the 3rd prime question, I tailor it to either benefits or side effects, knowing I'm probably going to cover both, but I'll pick the most important one for that drug. But coming back, I think if we ask that 3 questions to all patients, first of all, we'd stop talking to them and start talking with them. And you notice they're tailored questions. They're not rote, and they won't be the same for every patient. They're just concept areas. Number 1, we're going to start talking with them. We're going to find out what they know, and we're going to be able to correct misunderstandings quickly. And these 3 prime questions were designed to be used in a couple minutes. Right? This replaces that, what I call the pharmacist monologue, right? This replaces it with a dialogue. It's really quick and easy to learn, though it's hard to break the habit. There's a lot of tips and tricks we've developed to help people successfully ask these 3 questions, because it is hard, and it is hard to change your habits. So you can say, but you know what, you have 3 minutes with a patient, and this X intervention only takes 30 seconds. What's going on here? And then we find out they're actually afraid of opening the box. Because once we get a patient started and we find out what's going on, how am I going to fix it? Right? And, am I the right person to fix it? And can I do the right thing for this patient? So I think pharmacists, because we've been practicing in such a giving information, we haven't been used to taking information in and dealing with it as much. Not all of us. Like, I'm making broad sweeps here, but I do see a lot of this going on. And they're a little bit afraid. And I don't blame them. Who knows what patients are going to throw at you? Right? I think pharmacists just have to believe that we're able to handle it, because I know they are. No one doubts the knowledge of pharmacists.
Thanks, Lisa, for a great discussion. What are your final thoughts on this topic for us today?
I think pharmacists truly have to decide what their role is. And I believe pharmacists' role is to monitor therapy and to work with patients to do that. Databases as well, but we need to work with patients to do that. And I think once we start enjoying our jobs that way, there's no going back.
Thanks, Lisa. Nice slingshot, Blue Man.